Okay, good afternoon, everyone. My name's Bridget Fletcher. I'm the Chief Executive of Airedale NHS Foundation Trust. And I'm here to talk to you about technology that we've been implementing at Airedale. Jeremy Hunt came to visit us back in January, and he came to have a look at our frail elderly departments, talk to some of our staff, and also to have a look at our technology. And this is what he tweeted afterwards, which we were really proud about. And he continues to talk about Airedale and the technology he sees in the subsequent months. In fact, I saw him yesterday, and he was talking about it again yesterday, so it's clearly made a big impression. And it was on the back of that we were invited to come and talk to you here today to let you know what it was all about. So I'll just give you a bit of context, really. I mean, Airedale Foundation Trust is an acute hospital and some community care that we provide up in West Yorkshire and going into North Yorkshire. We've got the same problems that everyone else has got. So we've got rising demand in terms of frail elderly. We've got increasing patient expectations. We've got thinking about the future, really, where the patients really want to be more partners in their care rather than just passive recipients of care. And then we've got the money, the huge financial squeeze, and our current model in the NHS is not really going to be fit for purpose, as we have to meet all of these competing demands over the coming months and years. So we're really trying to think about what we're about as an acute provider. We're working very closely in partnership with primary care, community care and social care to really think about what our population needs. And it is a much more integrated system. It's one that's much more focused on the patient. It's one where we really want to make the default position the patient's own home rather than coming into a hospital setting. And what I want to talk to you today about is two things, and Richard's going to talk to you about one thing and I'll talk to you about the other, which combined make up the technology that Jeremy Hunt saw. And that is our shared patient record across primary, secondary and community care, which Richard will talk to you about. And then I'll come back and talk to you about our telemedicine. And then we'll take some questions at the end of it. So over to Richard.
Thank you. Good afternoon. There probably will be very few people in the room who don't know about TPP System 1, which is the system that Bridget is referring to. But just in case and for clarity, the system that we've used to create this shared record across the community, it really centres around a centralised patient record, which is absolutely massive now. I've just been talking to them on the stand and they tell me there are 26 million patient records in that repository of data. And of course the data can then be surfaced through a number of different modules, and you can see them on the slide here. And what that means is that not only are the GPs able to see their record, but we can then share laterally, if you like, across all the dimensions of this slide here, apart from the prison sector. System 1 is used extensively in the prison service, but it's in a walled-off section of the service, the system. So the power is there from a technological point of view. When you go to use it, of course, one of the things we have to address is the issue of the share and how do we get consent to share. And we've moved from a period 10, 12 years ago where it was really very difficult to get people to consent to share to one where people now accept that, you know, this is the patient's record and there is a duty to share where it's appropriate so to do, and you'll be aware of the latest Caldecott documents in this regard. We're also moving from a point-to-point sharing process to one of enhanced sharing where the patient says, yes, I want my record to be shared, and then it can be. And that will be significantly better from our perspective in terms of making this record available where it needs to be viewed by people who are involved in delivering care. So what are the benefits of doing this from our perspective? The first one is the avoidance of duplication, and you know this may seem blindingly obvious, but actually when we go around the country it's quite clear that not many people are in a position to do this sort of stuff. This is a screen from one of my diabetic patients' records, and what we're seeing here is the avoidance of duplication in taking simple measurements, whether that's weight, height, BMI, blood pressure, blood glucose measurements, laboratory tests, the whole gamut of things. It's very good for us from an efficiency point of view. We stopped taking regular weights and measures in our diabetic clinic about 8 years ago. But it's also really good from a patient's perspective in that they get completely cheesed off with being asked again and again, what's your blood pressure, what's your weight, what's your height. We can see what happened last week, last month, last year, and people value that. Increasingly looking forwards, the information will come from the patient themselves, and here's a very simple, trivial example of that where alcohol consumption is recorded by the patient in response to a very simple questionnaire. We know that people are often a little more honest speaking to a computer than they are to the doctor, so the ability to be able to view this prior to the patient coming into the room and start to form a view in your head of how you want to engage with that individual in a consultation is helpful. I think this is an area that's going to explode, really, this patient centricity in terms of the data coming from the patient, not just in terms of telehealth, which obviously is a big growth area in itself, but also the whole area of self-care where the person is actually setting the agenda. And I think it's very much watch this space in terms of the importance this is going to have for the way we deliver services. The other thing the shared record allows us to do is to take advantage of the choke point that is, in the UK, the GP record. It's very often the case that professional colleagues in secondary, tertiary care units elsewhere don't write to me, but they always write to the patient's GP. And because I can see through the GP record what's gone on, we've seen many examples of improved communication as a result of that. So you've got a list of all the communication that's gone on, whether it was directly to you or not, and you can drill into the data and see the detail of those letters. Now, a very timely example of that, a few weeks after we went live with the hospital instance of System 1, we had a patient in who'd had a transient ischemic attack. Our stroke consultant was reviewing them on a Sunday and was able to use this sort of bounce back view, if you like, of what had gone on elsewhere to see that they'd been admitted to Leeds in the previous week and had detailed investigations, was able to see the results of those investigations, the management plan from Leeds, and therefore to change our own investigation plan and deal with that person much more efficiently. We have a narrative record largely. I should have given you a health warning before I put this one up. But why in such a visual subject as medicine do we not incorporate pictures and video and images and sound and everything into the record as part of the record itself? And we're starting to do that now. These are pictures of a residual limb ulcer in a person with diabetes, and you can see, a picture is worth 1,000 words, and this is something we're trying to build on as time goes by. In terms of changing not just the efficiency but the actual nature of consultation, e-consultation, sharing the record across primary secondary care in order to get a clinical opinion is something that we've been working on in a formalised way, and this is work that's really been led by a GP called John Connolly in Bradford. And what John has done is to spend a number of years building up experience of the safety and efficiency of doing this. So on the left-hand side of this chart, you can see renal medicine, e-consultation going on. The need for face-to-face consultation went from 98% following a paper referral to 50% following an electronic consultation referral. And the time taken for the opinion to get back to the GP went from 5 weeks to 5 days. This was published and really set the scene for what is now an exponential growth in e-consults across a range of specialties. And as I say, led by John Connolly and his colleagues at Bradford. These things are going to change the way we consult. They're going to change how we think about outpatients and perhaps even about inpatient spells. We have taken TPP System 1 on in the hospital, and we're doing it in a series of tranches. And you can see some very straightforward things, whether it's order comms or clinical pathways, scanned records, all appearing through this electronic route over time. For me, the really important bit is the clinical pathways, because it's actually changing the paradigm of how we think about what a pathway is, what an opinion is, that will take us to this sort of new efficient NHS that we're all after. And so the goal for us is to finish up in a place that looks like this, where the ring that holds together the business aspects, the patient centricity, the clinician centricity, and new ways of working is actually the EPR, the electronic patient record. and that all the sort of bolt-ons, if you like, are bolt-ons to the EPR, because the EPR has something to contribute, whether it's business intelligence or clearly in a consultation setting. We feel that this newfound ability that we've got to share across the community is something that's really opening doors for us. One of the areas that it's doing that is in the area of remote consultation, and I'll hand back to Bridget to talk about the work we've been doing in that area.
Okay, thanks very much, Richard. So I'm just going to orientate you to what we're talking about when we're talking about telemedicine. So there's lots of words with the word tele in it, and people have different views on what they are. So I just want to put some clarity about what I'm referring to here. So telecare is really in the social care domain, and that is people with remote alarms and pressure pads and that kind of thing, so that it's really keeping people safe in their own home. Telecoaching is really about telephone advice and support. And then we've got telemonitoring, which is the boxes that patients have in their own home that look at their vital signs, blood pressure, that kind of thing, and can send data down a line through to either a call centre or a clinical call centre. What I'm talking about today is teleconsultation, which is on top of that it's really video consultation through to a specialist. So it's through to a specialist nurse or a GP or to a hospital consultant. And this is really about transforming the way that we deliver advice, support, diagnostics, consultation, treatment planning through to patients. So instead of bringing them into ourselves, we actually turn it round and we take the expertise through to the patient in whatever setting using video conferencing kit. So our journey here has been over 7-8 years now. We started off in prison health, and I've got a lot of experience of delivering consultation, mainly emergency consultation through A&E or outpatient type consultations through to most specialties. We're live in 20 prisons at the moment. And what we noted from our learning there was actually about 50% of the patients who had a consultation remotely didn't need transferring into a hospital care setting or some kind of a treatment care setting, because that diagnosis could be made using this technology. And then we started thinking about it, well, what if you transferred this into mainstream activities, into mainstream NHS care? You know, what could that mean? We noted this 50% change in patient flow, and that was for urgent care patients. For elective outpatient type consultations, that was even more, 60 to 80%, depending on the specialty. And we've done a large number of these consultations, so we've got the learning, and we understand that it works, so we've gone through all the pitfalls, really. So now we've started expanding that philosophy out, if you like, and are delivering care patients with long-term conditions in their own home. We use a set-top box that we've developed with a partner, but that goes into the TV, and it's very easy for the patients to use. And you're putting the control really into the patient's hands there, because when they feel that they're, for example, if they've got COPD, if they're becoming breathless, their condition is becoming out of control, instead of dialing 999, which often these patients do because they get panicky and short of breath, they actually dial through to a digital hub that we hold within our hospital, which is manned by specialist nurses and linked through to specialist consultant consultations in a very short period of time. So it's instant 24 access for those patients, with a link through to helping them solve their problem. The other area that it really makes a tremendous difference is into nursing and residential homes, and we're rolling out across all the nursing and residential homes in our patch at the moment, and are also into patches outside of our geography, where we can provide that 24-hour consultation remotely. And we're seeing an increasing uptake in this, and the results that we're getting, I'll show you a bit later on that. There's also supporting end-of-life care patients. This is with portable devices, really, that they can take into their own home. You can still get that video consultation, and making quite a big difference to those patients' experience when they're in an end-of-life care setting. we hear stories from them. We had a story told at our trust board a couple of months ago from the relative of a patient who died. And it meant that this lady could fulfill the commitment she'd made to her husband to care for him at home. And actually, without the telemedicine, she couldn't have done that. And she's our biggest advocate, really, for this equipment. And it's also got lots of other applications in terms of stroke patients. You can network from one hospital to another, run from an A&E department into a consultant's laptop at home, if you like. So we can actually give remote consultation out of hours as to whether thrombolysis is necessary or not across different health economies. So it's got lots of applications. So just in terms of some of the results, you can see here, it's only a small number, and we're doing more research on this and audits, but it's sort of reflecting what we found in the prison experience, is that for 25 COPD patients cared for at home, for the year pre and the year post their admission, that was getting on for 30% reduction. And then when you translate that into bed days used, it's even greater, because almost 40%, you can get these patients home more quickly because you've got the confidence that they can still get that expert opinion. So in a way, you're taking the expert opinion out of the hospital setting or out of the GP's consultation room, out to the patient. And this is our nursing and residential care home results. This is on 6 months data. And again, you can see quite a stark difference there between care homes with or without teleconsultation. And we compared those where we put in enhanced community care, if you like, with community geriatricians and specialist nurses going in to help educate the nursing homes and to support the patients in there. And that showed quite a reduction. But when you overlay that with the telemedicine, the video consultation, you can see there's an even greater reduction in admissions, which is much, much better for the patients. We all know how disruptive that is for patients being transferred out of a nursing home into an A&E, where often they die within the next 48 hours of admission. It's a much, much better quality of care. And we know with these patients, once they're in hospital, it's very, very difficult to get them out again. They deteriorate, the dementia gets worse, they get a UTI, and. So it's really trying to think how we get our expertise into the patient in their own care setting, making their home the default position. And this is what the evidence is showing us. When we first started out on this, a lot of people said, oh, the patients won't like it, they'll really not want it, they'll want to see the doctor. Well, actually, the opposite is true, and you'll see some of the feedback here, both from the patients and from the staff in the care homes, etc. It's very much liked by them, and it gives that control back to the patient. So it's about the patients as partners and the patient in the driving seat, as it were, instead of them being these passive recipients of care. It just gets stronger and stronger. The more experience that we get, the more evidence we're getting of how the patients like it. As I spoke about before, there's lots and lots of applications. This just demonstrates to you some of the facilities that we've got the video conferencing in. But just use your imagination, for your own services that you provide. If you could get your expertise out to your patients, your clients, in a much more speedy way, much more holistic way, just imagine the changes that could make to the system we run now. So this old-fashioned system of primary care and secondary care being very separate and the patients having to find their way around that system, it actually helps join them together. If you think about that with the single patient record as well, that all those professionals can see, we've got the makings here of a very different shape to our NHS for the future. And I really believe that, we need less of a bed base in acute hospitals. We need more care in the patient's own setting. This really enables us to do that in a very different way. This just lists out some of the benefits, the whole productivity thing as well. So if I can take a whole ward out of my acute trust, I can save £1 million. That's big money, and this is a lot of the money is held up with the acute patients coming through, with frail elderly who use a huge amount of the resource. And if we can care for them in this different way, then, we could make huge productivity gains. And we've done quite a bit of modelling on the finances of this, and we can deliver, when it's done at scale, which is the important thing, we deliver efficiencies to the commissioners and efficiencies to the providers, so it's a win-win all round. But my strong message is we have to do this at scale. This is about a mainstream change to the NHS. And I would say seeing is believing. This was Jeremy Hunt in our digital hub. He was blown away by it. I put an invite out to anyone in this room who'd like to come and see it and talk to our staff, because actually, when you see it, your imagination really starts to run with it, and you can start to visualise a different way of working. So thank you very much for listening to us.
Well, there you are. It answers so many questions, as you said, Bridget, about primary, secondary care and blurring the difference and making the health service more effective, because there's so much duplication. And one of the presentations before was that if you have a written, about e-referral, that if you do a written referral, it adds 2 weeks to the waiting time. I mean, we can do so much. Anyway, that's enough from me. Anybody want to quiz? And one there, lady at the back, and then there's a man in the red shirt.
Hi, Chris Campling, lead for Plan Care for Aylesbury Vale. Just wondering how you jig the consultant at the end of the line. We're increasingly finding super specialised physicians. So you're either respiratory or you're cardiac or you're diabetes. And most of these patients, have a bit of everything. And when they tip over, there are implications for everything. So how do you gear up the consultant at the other end, please?
I'll take that then. Basically, we use experienced Band 6, Band 7 nurses at the first tier. And in fact, they're able to deal with 80% of the calls that we get. If we do need to escalate, we would typically escalate in working hours to an acute physician who will be on a 15-minute recall time. And beyond that, direct to specialists. And I think that one of the service changes we're going to have to engineer is a different tasking of our consultants, so that they are tasked with an outward-facing role, not an inward-looking role. And the only way we're going to get control of the flow of patients is if we do that, and we stop people from hitting the A&E or the admissions ward in the first place.
Could I just say also that even though obviously the big increase is in comorbidity, within that it's often the individual disease that is the present flare-up. So even though you have a holistic view of life, and that could be in primary care, you need both. You need the specialist and the generalist working together. Gentleman in red t-shirt, whatever he has.
Hi, Ahmed Myatt. I'm the urgent care lead for Mid-Essex ECG and GP. Two-part question, did all the GPs use System 1? And if not, how did you link with their surgeries? And the second point, how long did it take to train the hospital from whatever paper-based to a system to a paperless system? And some people say it takes a year to get used to that. And what did you do in the meantime when you had that problems?
Okay, two good questions. The first one, almost all our GPs in our natural catchment population are on System 1. And so that's not an issue, but we do link to a number of practices where other systems are used, and we use System 1 within the hub to via DTS messaging and NHS mail, whatever is required by that practice to send information to those practices. In that situation, we can't see the patient's record, so it's limited, but it is still allowing us to communicate in real time back out to the primary care team. Regard to training, it's a long journey, this. I bear the scars of some of these discussions with colleagues in getting them up and running, but it's one that has accelerated. So, more people have seen it in niche areas, if you like, within the hospital, and now as we roll across the whole hospital with a very structured formal training program, it's becoming easier to engage people, but it does take time for sure.
One of the interesting things, given how we've faffed around with the summary care record and not got very far, it strikes me that what you're doing locally outwards rather than trying to impose a national thing has more buy-in and patients are more likely to say yes and all the other things. And we were just informed in a previous session that Wales has done an integrated health record for out-of-hours specifically with the same positive things that most patients are very happy.
Yeah.
Whereas we've probably gone the wrong way in Britain of trying to, England, of trying to do a top-down, too big a thing.
Yeah.
But it's interesting that, I mean, this is sharing information which everybody makes a big fuss about, and
Yes,
you seem to have got over that governance problem.
Yeah. Yeah.
Gentleman there.
Thank you. Bill Tamkin, GP Chair in South Manchester. Does this link with social care, with the mantra around integration being so important these days? Is there a link to social care records as well?
Is this not? Not yet, but our local authority are looking at which system to procure, and they're looking very closely at System 1. So we think in the future that would be the case. But we can communicate in some way. And in terms of the telemedicine using the video conferencing, we're also having conversations with adult social care about how we can include social workers in this kind of video conferencing setup, because it's often the same patients who need some, social input as well as health input. So there's two ways to look at it.
Gentleman at the back.
Hi, Andy Warrington, GP in Somerset. Could you just give an indication of the unit price of the set-top box and just describe a little more the process of a patient initiating a call if they live on their own at home?
Let's test them, won't it?
I think rather than give you a price in one sentence, I'll point you at that man there, who will give you the answer to that. But basically, if we avoid one admission from the person at home, then the commissioner is seeing a surplus, they're making a saving, and it's a real saving because it's the avoidance of spend for an admission or an outpatient or any attendance. So, you're looking at about 2,000 something a year, something like that.
Very focused GP type question there.
Can I just add to that, though? I think that the more it goes at scale, the more the unit price will come down.
Yeah.
And, I think we're going to see a downward pressure on the price.
Can I just add, if you want to see the set-top box, it's on D25. It's on stand D25.
Excellent. Well, I've got time for probably one more because this is brilliant. Gentleman there, and then I'll better call it. But please visit the stand, obviously.
Hi, thanks for the session. I mean, it's always good to have a chief exec talk about IT issues. That's generally not very common within the NHS. I work for Brompton Hospital in London. Wanted to know whether you had any IG-related challenges in the teleconsultation setup?
It might be possible. We don't use Skype, we don't use FaceTime, partly because we don't know where the servers are and we're not sure about encryption and so on. So this is a fully encrypted service, industry standard video conferencing protocols, and we've worked up the IG rules about how we will identify a patient, communicate with them and so on, and I can talk to you separately about that. I mean, I think actually it's safer than many other things because of the nature of video. You're not going to hack it.
Well, can I thank these two brilliant people again for that super presentation? So thank